Hello and welcome. My name is Sarah Rosendahl. I work in the Springfield-Greene County Library District's Community Relations Department and as Project Director for Death and Dying Conversations on End-of-Life Matters. On behalf of the library and the Series Planning Committee, thank you for joining us for this Death and Dying event, End-of-Life Care, Social Model Hospice Homes, and How They Work. This is our fourth year hosting the Death and Dying series, and we feel it's especially important that we offer the series this year to give people the opportunity to start conversations on these important topics. It's especially important as we're facing the challenges brought on by the pandemic this year. So bravo to those of you in attendance for starting this conversation with us. We also want to say thank you to the Hospice Foundation of the Ozarks for funding our series of virtual events, along with new materials on end-of-life topics that we've added to the library's collection, both hard copy print books and ebooks. So we're very thankful for the contributions of the Hospice Foundation, and we value their support for not only our series, but other end-of-life projects in the community. We appreciate you joining us to help break the taboo of talking about death and start a community conversation on end-of-life topics. We hope this event and the Death and Dying series as a whole inspires you to continue the conversation that we start here with the people in your life. Our next event is Funerals and the Impact of COVID-19 at 6 p.m. on Tuesday, November 10th. The complete schedule of events and titles for suggested reading can be found at thelibrary.org/death. They are also available in program guides and Bookends magazine and bookmarks that are available at all branches. You can visit thelibrary.org/death or thelibrary.org/programs for links to these virtual events. Before we get started with the presentation, a reminder that the library continues to offer programs for both adults and children. We're just offering them in a virtual format for now. If you'd like to receive emails about upcoming library programs tailored to your interests, topical book lists, or library news, please visit thelibrary.org/newsletter to sign up for periodic updates. You'll be the first to know about library news and events, and the emails make for handy reminders. I also want to let you know that this session will be recorded for sharing on our social media platforms, including YouTube, for those that weren't able to join us for this live event. Watch our channels for the link if you'd like to watch this again or share it with your friends or family. One more bit of housekeeping. Please keep your mic muted through the presentation. We have a few speakers this evening and want to make sure everyone can hear them clearly. We'll have time for Q&A at the end, but feel free to share your questions and comments anytime via the Q&A and chat functions in the Zoom panel at the bottom of your screen. I'll relay them to our presenters at the end. If you encounter technical difficulties, please let us know in chat. My coworker, Chrissy Seiner, is our Zoom master this evening and will provide us with the technical support we need as necessary, and we really appreciate her expertise. We're so pleased you could join us this evening for End-of-Life Care, Social Model Hospice Homes, and How They Work. Hospice homes and end-of-life care centers are unfamiliar to many of us, but are an essential part of the end-of-life conversation as we talk about helping our loved ones and ourselves towards the goal of a good death and changing the norms surrounding end-of-life care in the U.S. Our presenters this evening are very well versed on this topic, and we are delighted that they are with us this evening to help start this conversation. Our first presenter will be Kelley Scott, founder of Clarehouse, a hospice house in Tulsa, Oklahoma. Welcome, Kelley. She's also the founder of the Omega Home Network, a national membership organization that promotes the development and expansion of community homes for dying people. Following Kelley, we'll hear from the current president of the Hospice Foundation Board, Dr. Regina Waters. Welcome, Dr. Waters. Dr. Waters is also Associate Provost of Adult, Online, and Graduate Education at Drury University. And lastly, we'll hear from Alecia Robinson, Executive Director of the recently opened Jacob's Ladder End-of-Life Legacy Home in Springfield, and what that means for our community. Welcome, Alecia. Thank you all for sharing your expertise with us this evening. Kelley, if you'd like to start us off.
So I just want to thank you for inviting me here tonight. I'm honored to be able to participate in your community education. This is something that I feel very passionately about, and we at Clarehouse feel passionately about it as well. There are so many issues with end-of-life care and planning, navigating the healthcare system, learning how to advocate for someone you love, and learning about it in advance is the best possible way to prepare. It's really, really difficult to gather and process all this information and then be able to discern the right path for you or your family when you're in the middle of a life-threatening illness with a loved one. So I commend you for taking the time to attend and listen to this tonight as we share with you what a solution is for that caregiving crisis for final days care. So this has been a quote that's been inspirational to me since back in 1986 when I graduated from nursing school and read Anatomy of an Illness. Death is an opportunity for growth and self-actualization and deep significance and meaning for a family, but too often it's just a tragedy of a sterile, depersonalized experience that becomes something that the survivors simply want to put behind them and forget about. There's opportunity to make it much, much, much better than that. But for most people, they need help to do that. And so learning how to access that support and the services that are available to you is the first step. What final days care really faces is a challenging gap in care. Many people are familiar with medical hospice services, and they are a wonderful package of an interdisciplinary team that is provided through the hospice Medicare benefit. It really is the best managed care service that the government, I think, has ever come up with. But it has its limitations. What medical hospice provides is a team of professionals, a nurse, an attending physician, a social worker, a chaplain, a home health aide, all the medications related to the terminal illness, all the durable medical equipment that might be needed to provide care for someone in the home. But what they don't provide is a place to live in the 24/7 care. In final days, round-the-clock care is usually needed, and it is really difficult. It is exhausting, it's physically burdensome, it is financially devastating to a lot of families. And not having a reimbursable source to cover that need through Medicare or private insurance is not what families want to hear. It's not something that most people know in advance. In my practice as a hospice nurse for over 30 years, what I found is that most people learn this bit of information when they're in the middle of trying to navigate that care. So they think that, of course, they've got a loved one that's dying and they're going to be able to stay in the hospital, or they're going to be able to go home and have help in the home with them 24/7. And it's simply not available. It's simply not a part of the package that exists through coverage of private insurance or government insurance. Caregivers are faced with a lot of challenges. One of the most common situations that we see in our home here in Tulsa are elderly couples that are alone. Their children have moved out of state. They're trying to manage this on their own. They're trying to stay independent and stay in their own home, but they may be in their 80s, and maybe it's a 80-year-old woman caring for her 85-year-old husband, and he outweighs her by 50 or 80 pounds. And there's no way, once he becomes steadfast, that she's going to be able to provide the care for him that he needs to stay safe and clean and dry and comfortable. Oftentimes it's a family that is the caregiver still working, and there's no way that they can take off work or continue their job and stay up all night long taking care of their loved ones. So needing to still work is a huge, huge issue. For a lot of people in that sandwich generation, they've got small children at home and they've got an elderly parent that's living with them or that they're trying to visit daily and nightly to take care of them as well. Hopefully you come from a functional family. I think you'd be in the minority. I think there's a little bit of dysfunction in all of our families. And a time of crisis is not, as much as we all hope it's going to, a time of crisis is not necessarily going to bring out the best in all of us. We're not all going to function better at a time of grief and a medical crisis as what we function in everyday life. So if you've got a sibling that you disagree with on everything, you're probably going to disagree with them somewhat on the care that's going to be provided to your mother or father. That kind of family conflict is so normal and so typical in our society today, and not something that we address enough. And then sometimes the challenge is simply the environment, that if the home situation, the physical environment makes it really difficult to provide adequate care. Or maybe it's a homeless person that doesn't even have a warm bed to lie in because they don't have a house. So all of these things add to this existing crisis that exists for us in this country. 48 million people are serving as caregivers for adults in the United States at this time. 8 million there's been an increase of 8 million in the number of caregivers in the last 5 years. A lot of these caregivers who are over 75 are caring for someone who's over 75. There's so many issues that are a part of what's adding to this crisis. 45% of caregivers report at least one financial impact because of caregiving. The even scarier statistic to me is that the majority of bankruptcy in this country is due to medical debt. 53% of caregivers experience a work-related issue because of their role. 61% are continuing to work while they're providing care. And look at the average duration of caregiving, 4.5 years, if this goes on for a lot of people. You think it might be something that you're going to have to deal with for 2 weeks or 2 months, but 4.5 years, Alzheimer's and the related dementias are a growing diagnosis in this country, and that is the long, long goodbye. So you may be talking about up to 10 years of caregiving for someone in that situation. So what do we do to bridge that gap between what medical hospice provides and that care that's available towards the end of life, and what a family can provide for someone that doesn't have family that needs, rears its head even earlier? What is available through medical hospice is generally considered up to 6 months life expectancy. So if you've been fighting a terminal illness, and you get in that window where your primary physician thinks that you've got about 6 months or so to live, hopefully that doctor is going to recommend hospice. The trend over the last several years has been that those referrals are being made later and later. So a lot of people are not being referred to hospice until they're weeks before death, sometimes days before death. And that's a disturbing trend that we're seeing as physicians seem to hang on to people longer, healthcare systems seem to hang on and treat people longer, well past the time when that treatment might be futile. So again, that's a whole nother education process, but learning about navigating serious illness and learning how to have goals of care conversations so that you're able to sit down with your healthcare provider and ask, what are we hoping for here? What's the best case scenario? What's the worst case scenario? With this treatment, what can we reasonably expect? What are the goals that are associated with this? And what is the quality of life that might be associated with this as well? Sometimes you're only going to hear about the quantity of life that a treatment might bring, when some real questions need to be asked about the quality of life and what that might be as well. So in that conversation, as disease progresses, as death draws near, the challenges get more intense as the caregiving becomes more intense, and the person actually experiencing the illness gets weaker and more dependent. So what are those options when someone can't take care of themselves anymore and there's not enough family or friend support to help someone stay in their own home? And what we came up with in our community was this solution of providing a community-supported home that would provide that 24/7 care. We didn't need another hospice in Tulsa. In 1999, 2000, when I first started talking about this vision of care in our community, we had about 45 medical hospice programs. Now we have over 80 medical hospice programs. It is a growing industry, for good or bad. It is a rapidly escalating industry because there is government reimbursement available for this service. But it does not cover that 24/7 care. So no matter how many medical hospices you have in your community, it's not going to meet this need that we're trying to address with the social model hospice home. It is an alternative collaborative partner to the traditional medical hospices. And that's one thing that we try to teach people to be very clear about. It is not the same thing. We are not a medical hospice program. We are designed for and totally focused on care at the end of life, and that is final days care, usually weeks to a few months at most. There is a paid staff in our homes, but we have strong reliance on community volunteers. And it is truly a home, it's not a medical facility. We are not a clinical environment, not an institutional environment. It truly is a home-like space. We are a grassroots organization that is created by the local community. There's nobody going around starting hospice homes in cities all across the nation, as far as one entity doing that. These are born out of the vision and the passion and the commitment of a local community. And we are all independent nonprofits. The Omega Home Network is a national membership organization that we support and foster each other through, but we are not dependent on each other in a business structure, financially, anything like that. We're all independent nonprofits. And we simply describe ourselves as a loving home to dying individuals. Some people call it social model hospice, some call it comfort care home, some people call it a home for the dying. Whatever the name is in that local space, it depends on what the community chooses. But for all of us, we offer this haven of loving care for people who are enrolled in medical hospice but cannot stay in their own homes for the last days or weeks or months of life. We become home and we become family to dying people in need. So the vision is that these homes are focused on quality of life with access to medical hospice. So everyone that lives in our homes has to be enrolled in a medical hospice program. That's a great collaboration. Those services exist. Those patients are already in those hospice programs out in the community, and the medical hospice is responsible for case management. So they provide that nurse, the social worker, the home health aide, chaplain, the medications, the medical equipment. They're already being paid by Medicare to provide all that. They just provide all that now in our home when they come to live with us. So the avoidance of duplicating services is really important and really key to the model, because we're collaborating and fostering the continuum of care without duplicating services that already exist. And it allows that social model hospice home to operate on a much more economical basis. We all provide services regardless of ability to pay, depending on state regulations and licensing. Some people may charge a sliding scale rate for people that come to live with them, and some places don't. In Oklahoma, these services are offered 100% free of charge, and in lots of other states as well. There's always strong community involvement. We're really dependent on volunteers to help with every aspect of care, from strategy and planning on a board of directors, to fundraising, to committee work, marketing, messaging, to the actual care that goes on in the home every day. Somebody that welcomes people at the front door and helps them get where they're going, that is providing a loving presence at the bedside, vigiling at the time of death, cooking, cleaning, laundry, all of those things that it takes to keep a big busy household running. And we really try to be a place that is the next best thing from home. Nobody wants to leave home necessarily, but if we can be the next best thing, that's our goal. So I have a video of Clarehouse, and I want to show that to you, but I show it to you with the caveat that you have to understand this is not where we started. This is a big, beautiful home. It's 14,000 square foot home on 6 acres of wooded property with a creek running through it, and it is a serene, beautiful, natural haven. But we started in a 3-bedroom apartment that we rented that was 1,000 square feet. And we were in this very modest, very simple apartment that was not handicap accessible. It was not built for our needs. It became sacred space because of the living and dying that happened there. And we stayed in those apartments for 6 years. We eventually rented 4 units in one apartment building. And we lived there for 6 years, and over 1,000 people died in those apartments. And it was, as I said, sacred space. Nobody cared what it looked like. Nobody cared that it wasn't a big fancy place. There was a lot of love in those rooms and in those apartments, and it was wonderful for us. But we grew, and the need for our services grew, and the giving in our community grew, and we were able to do a capital campaign and raise the money to build a permanent home that was purpose-built for our needs. So we gathered up everything we learned in those 6 years of apartment living and designed a dream home of what would families need, what would dying people need to achieve the highest possible quality of life that they could during their final days care. And we created a space that does that, and it's beautiful, and that's what I want to share with you. So that's Clarehouse. I've got pictures in these slides of homes all over the country that are members of our network. So you'll see pictures of other places as well. And as I've said before, they're all home for their local community, whatever they look like, however they're designed, however they're decorated, they're all home. And they're really, really welcoming environments. Hospitality is a huge part of the culture of our homes. We're all here together. We welcome families. You know, things are different right now with COVID, but in normal times, the camaraderie that exists between the family members that are finding companions in their journey is an amazing gift. Not often that people have an opportunity to share this kind of experience intimately with someone else that's going through it. And what I've seen from the very beginning in the apartments was that families would connect in the common spaces in our home, and they would start to talk, and they would start to tell stories, and they would get to know each other and watch what was happening. And people that were farther along in the process would be sharing what was coming, and people that were earlier in the process would be watching that. And when that loved one died, that family next door would be a part of the support that was offered to that grieving family, and they would get to see that whole process. And it's kind of a learning process for them, and like a practice run of what it might be like for them. And I think that's a really unique opportunity through our homes, is to give people that community experience of dying, because dying in community doesn't really happen anywhere else. besides a really institutional environment that might not have the same sort of approach to it that we do. So very non-institutional space, residential furnishings and fixtures. You know, we have a 10-bedroom home here, and we don't own 10 of anything. So we didn't go, when we were decorating this home, we didn't go buy 10 of the same chairs to put in a room. Every single room is decorated differently, and they all have their own personality and feel. It's very much like home. We've created different kinds of spaces for families. Generally, the one big room is not what people want. They all find their own little niches, and sometimes that might be a very small space. Sometimes they may sit in the living room, but a lot of times it's small spaces that they're looking for. We all sit down around the table together and eat in non-COVID times. We share meals. There's one family meal served every day in our house, and we'll all sit down together and eat. We're really lucky to have these beautiful French doors in all of our rooms that open out onto a deck or patio. So we've got access to outdoors, and that's everybody, all of our homes try to find some way to do that, whether that's through a window or some kind of patio space, gathering space for people to be outside. And then welcoming families to spend the night, that they're able to stay here as well if they want to do that. The loving support that is provided is very much a part of what we as staff offer, but it's also a huge amount of giving from our volunteers. So whatever gifts and abilities and talents people have to offer, we welcome them to share that with our guests and families here. And it might be music, it might be presence or prayer or massage, a yoga class. We have a videographer who volunteers for us, and she'll come in and sit down with a dying person who wants to tell their story or leave a message for their family to play at their memorial service. And Melanie will make a beautiful video and give that to the family for later on. Volunteers that will come and read to someone, or will take dictation and handwrite letters that person may want to leave for someone. Whatever the community has to offer, we'll find a way to use it here. We do offer a blanket to every family when they move into Clarehouse. We'll take a lap blanket into them, and that is a gift from many women around our community who knit and crochet, and so that everyone has a handmade lap blanket for their use while they're here in our home, but also to take with them when they leave. So how do you decide who gets to come to a place like this? We've settled on some general criteria for admission that are very consistent across the country. And those are that the care is focused on comfort. We don't do aggressive treatment. We don't do life prolonging measures. So no IVs, no tube feedings, no blood sugar management, really complicated dressing changes, tracheotomy care. We don't do any of that. We're not able to do that because we're not skilled nursing providers. We're not licensed. We're not regulated. We have a level of care that is consistent with what an average family member would provide in the home. And that also relieves a lot of conflict that might happen in these final days, because we're focused on preparing families for what's coming. And when their loved one loses the ability to swallow or loses their appetite or thirst, that's a normal part of the dying process. Our job at that point is to help that family understand that this is normal. There are other ways to nurture and love someone besides feeding them, and we're going to keep that person as comfortable as we can and keep their mouth care going so that they're not feeling that dry mouth. But we're not going to slap an IV in them and pump them full of fluid. It's not helpful and it's in fact harmful in final days care. But families don't understand that. So our role is to educate them in that. We're working with their medical hospice provider who is hopefully providing that same education, and we're working hand in hand to help families understand that. So we're focused on comfort care. We do not do treatments or any activities that prolong life. We also don't do anything to hasten death. We are simply walking the journey with these people as nature takes its course. Everyone here has a short-term life expectancy. So at Clarehouse, we set a standard of it's time to make a referral to Clarehouse when you think someone is in their last month or so of life. Now, nobody has a crystal ball, and we know that sometimes things don't play out the way that we might expect. And so we're okay with that. If someone lives longer than that month, we don't kick them out at the end of those 30 days. We reevaluate. And if they're still declining, it's just not as fast as we anticipated, then we offer to extend their stay. If they've gotten better and they're truly doing a lot better and they're eating and drinking and they're getting up and getting around and they want to go out, they want to leave for the day, those kinds of things, then we might think about this is a longer term care situation and they probably need to find a new place to go. We're not funded for long-term care and we can't do it. It's also a social justice issue for me. We only have 10 bedrooms. And if we were taking care of people that were living 6 months to a year, we'd be serving very few people in this home. We have a waiting list all the time, and we want to help as many people as we can. So putting that time limit on there is the way that we have found that sort of middle ground of helping people get here in time to make the most of what time they have left and enjoy as much as they can, but also for us to be able to help as many people as we can, because we're not becoming a long-term care provider. Other homes may make that a little bit longer. There are homes in our network that may say 2 months, 3 months, a few that say 6 months. What we find in our community is that unfortunately referrals come late no matter what. If we said 6 months, I think we'd still get very late referrals, and our medical hospice programs experience the same thing. Referrals come very late. So our average length of stay at Carehouse is less than a week. It's about 6 days. We do have people that are here for 4 weeks, 5 weeks, 6 weeks, but on average, it's probably about a week that they're here. Everyone that's here has made the choice to not seek resuscitation. So we're not doing CPR, we're not calling 911, we're letting nature take its course, and then they do have that local hospice that is their medical case manager. I know this is a really busy slide, but I like to share it just to see the difference between the medical hospice services at home, the medical hospice services in an inpatient facility, and contrast that with the social model hospice care. So in the medical hospice, whether it's at home or whether it's inpatient, that can be paid for through Medicare, Medicaid, if you're in a Medicaid state, and then some private insurance. All social model hospice care is free or sliding scale. That caveat that everyone that lives with us has to be enrolled in a medical hospice is also universal in all of the homes. We are not an inpatient facility, and we're different in that those inpatient facilities that are owned and operated by hospices fall under those same kind of regulations that the hospice itself does. And so they have strict physical plant requirements and professional requirements that are very expensive. And because of that, and the cost of providing an environment that meets all those requirements, an inpatient facility is very, very expensive to run. What the inpatient facilities that I have talked with, the way that they stay viable is that they take care of a majority of people who are at an acute level of care, because Medicare reimbursement for hospice comes at 4 different levels, and home care is the least amount of reimbursement. That acute care is the highest level of reimbursement, but it requires a symptom that's unmanaged, a crisis situation, something that somebody with good hospice care on a normal dying process doesn't need. And so the people that live at Clarehouse would not be eligible for the reimbursement under that acute care level in the hospice reimbursement. And that's the difference. So an inpatient facility is usually taken care of as much as 90% of acute care reimbursement level, not the routine home care reimbursement level that's so low. They have to do that financially to survive. So they're not meeting the need that we're meeting. They're two different needs. There's definitely a need for inpatient hospice facilities that provide that acute level of care, but the caregiver crisis is not being met by those kinds of facilities. And that's why it's so important that even if you live in a community that has an inpatient unit, you also need a social model hospice to deal with the caregiver crisis. So how do you start something like this? You know, articulating the vision, understanding what your community needs are, is really important. Begin to share that and start with your core group of people. I am the founder of Clarehouse and began talking about this vision with people about 5 years before we opened our doors. And our original board was 7 people. So it is possible to begin on a very small scale with a core committed group that doesn't have to be 25 to 30 people. So you establish that board of directors, you incorporate in your state, you get organized, apply for your 501c3 status through the IRS, and then develop a strategic plan of how you're going to raise the money and where you're going to provide this care. I think doing a temporary facility, a temporary home is the ideal way to do it, because for most communities, it's a new concept and they don't really get it. So you prove the model, you demonstrate the need, you demonstrate that you know how to meet the need and that you can provide a quality service and that you can continue to raise money to keep it funded. We rented with a 6-month lease, so that was our commitment. We had to raise enough money to pay that lease for 6 months and know that we could cover our expenses of salary and occupancy for those 6 months. So we pre-raised that money, and then we made that lease commitment. And we knew at the end of that 6 months, if we were broke, if we didn't have enough money to keep going, that this was not a viable option for our community. That was not the case. We had received enough donations and grants and funding as we went along that we were able to keep going. But I really encourage communities to start small and to start with that sort of temporary approach. The regulations might be different in every state. In the state of Oklahoma, what I learned in talking with the state health department is that they didn't have a bucket that they could put us in, and that freaked them out. They did not like the idea of not being able to put us into an existing licensing category, but none of those categories fit for us. And ultimately, what they wanted us to license as was a long-term care facility. That is not compatible with the vision of these homes. Long-term care facilities are all about health promotion, prevention, maintenance. They are trying to keep people as healthy as possible for as long as possible. And that's not what happens in a dying person's life. They are going to lose weight. They are going to lose interest in food and fluids. They're going to withdraw emotionally from the world around them, and they're not going to want to participate in activities. I've had so many families call over the years because they are desperate to get out of the nursing home where their loved one is dying, because their nearly unresponsive loved one is still getting up and being put in a wheelchair and taken to the dining room to sit around a feeder table and be fed when they're barely able to swallow. And these families are saying, why can't they just leave my mom in bed and let her not eat and do this the way that she wants to do this? It's very uncomfortable for her what they're putting through. But those are the regulations that they're dealing with in these facilities. They are going to get in trouble by their state if they have people that they're not getting up, that they're not trying to keep them going as long as they can. We've had nursing facilities in our community who have actually told families that they're legally required to put in a feeding tube. It's not true. It may be nursing home policy, but it's not a law, but it's being misrepresented to families because that they're just so uncomfortable with letting people die in their facilities. So all of that work has to be done up front to figure out how this can happen. For us, the state told us, if you don't want to be a nursing home, that's fine. There is a statement on the very first page of the nursing home regulations that says if you don't charge for your services, you don't have to be licensed in the state of Oklahoma. So by law, we can't charge for our services. We've been able to make that work for us through complete community support, and we're really lucky to do this. But we're not that unique. Other homes across the country have been able to do it the same way. So who does pay for it? Anybody that we can get interested and involved in our mission. Messaging, advocating, it's all a part of the role of every staff member, every board member, every volunteer. We're all responsible for getting out there and spreading the word and inviting people into the hub. We want as many people to help us and be a part of our home as possible. So individual donations are huge for us. That is the majority of the giving at Clarehouse. We do one big fundraiser a year. We put everything we can into this one big event, and it's grown from, I think the first year we made $16,500, and last year we raised $350,000, and it just grew gradually year by year by year. So that's a huge commitment and effort for our board of directors. We write grants to local, regional foundations. We've never written a national grant, but local and regional support from our foundations has been key. That's about a third of our income. And we learned that as we went along, how to write a grant. You follow the instructions, you answer the questions that they ask, and you try to make connections. We don't send out cold asks. We don't ask people for money that we don't know. We try to meet them first. We get introductions from our board, from people in our community. Do you know somebody that might be interested in this mission that we could tell our story to and invite them into our home and let them see the work that we're doing and ask them to partner with us, to invest in this with us. We get a lot of corporate support through matching gifts, and we get support from businesses who just send us donations. A lot of the donations that we get come to us in memory of people who died here. So you'll see that in the paper. In lieu of flowers, the family requests that you make donations to Clarehouse. And that's been a huge part of our income over the years. And then we save an awful lot of money because we're not buying toilet paper and paper towels and laundry detergent and crackers and soup and whatever we might need to run this big busy house. So much of it comes in every day. The car pulls up under the porte cochere and they unload 4 bags from Walmart, and there we go. We've got snacks and we've got cleaning supplies, and we've got stuff that we need to take care of our guests. So we have done some research over the years about the impact of our care, and we have documented that it has a positive effect on caregiver well-being as well as their bereavement. That we relieve the suffering of our guests, that we relieve those burdens on the caregivers, and that what we provide exceeds people's expectations. It's really sad how low people's expectations are for care, for this kind of care. They're shocked to be in a home where that is clean, that it doesn't run based on the priorities of the staff or the home. We are basing everything that we do on the priorities of each individual in the bed. They get to give so much input about what they do and how they spend their day and what kind of schedule they're on and when they want to eat. It's not built around us. In bigger places, in hospitals and nursing homes, of course, that machine of the institution has to drive the priorities, because that's how you survive taking care of 200 or 500 or 1,000 people in one building. But that's the beauty of such a small home. We get to base those priorities on what that person in the bed wants. If you haven't looked at the Institute of Medicine's report, Dying in America, that came out in 2014, it's really worth the read. The link is there, and I can put that in the chat later. But it talks about how poorly we die in this country and how we can fix that. And so what the report indicated needed to happen was that care became patient-centered, family-oriented, round-the-clock, consistent with individuals' goals, values, and preferences, and collaborative. And that is the definition of a social model. It is an ideal solution for the Institute of Medicine's recommendation. So over time, we started Clarehouse not having a model to emulate. We looked all over the country and couldn't find anything but inpatient hospice units. We couldn't find what we were looking for. So we started based on our own vision, and we made it up as we went along. But over time, as internet searches have advanced, we found homes like us, and we found homes older than us and bigger than us that have been doing this for many, many years. And we've been able to connect with them, and we mentor projects and we invite them in for site visits. And a few years ago, we formally created a network, a national membership organization for all of our homes. So we're able to share and promote and expand the model. We all pay it forward, and we help the next project. We try to provide education to our communities about how to live well through dying. And we just continue to try to serve the model and the expansion as much as we can. As I said, we started with 7 people, so never doubt that a small group of thoughtful, committed citizens can change the world, and often it's the only thing we do. So thank you for listening to our story and the story of the model.
Thank you very much for sharing your story, Kelley. That was so inspiring, and it's an amazing mission that you all are serving at Clarehouse. We're so fortunate to get to hear about it this evening, and there's some other people that are very passionate about the same cause in the Springfield area, and so please, Kim Morelock and Regina Waters, please fill us in on the Hospice Foundation's role in the hospice home concept.
So, I am watching in awe, as I always do anytime Kelley speaks. I found myself going through the tour and knowing that I was there in person and getting a little choked up. So it is an amazing place, and it's amazing people. But what I know is Springfield has a lot of amazing people. And Hospice Foundation is absolutely thrilled to be a part of this project. It is something personally very near and dear to my heart that I found Kelley in about 2010, and we have remained friends. And I kept telling her, this is going to happen. We're going to make it happen in Springfield. We need it so badly. And I had the privilege of becoming the executive director for Hospice Foundation of the Ozarks in 2017. And Hospice Foundation has a heart for this mission, and mission-driven partnerships and collaborations, and reaching the community and making sure that no one dies alone. And we have provided the funds to start this, and we are extremely proud to be a part of it. Regina Waters went down to Clarehouse, and we toured it together. And I will let her take it from here, because she has a heart for hospice. She has a heart for those that are dying. And I think that Clarehouse sparked something in her, and she will never be the same.
Yeah, thank you. I share Kim's accolades for what Kelley has managed to create in Tulsa. I call Clarehouse the mothership. And it was a transformative experience to get to tour it a couple of years ago. When I first, it's been several years ago, I got to know the Hospice Foundation of the Ozarks. They asked me to facilitate a strategic planning session for them. And they were at a very critical juncture right here in Springfield. They had a vision for the kind of care that Kelley's talking about. But how do you do it? And I am so glad for those of you on this session tonight, you heard Kelley step you through what a social model hospice is, and it's not a medical model. Finding the right vocabulary and the understanding to try to describe this to people, and how to create awareness and comprehension so that people say, yes, I want to be a part of that, is very difficult. So I had heard those words, but it wasn't until I walked in the doors of Clarehouse in Tulsa and saw what happens in that home, not that facility, but in that home, it truly, it changed me. And the fact that folks in our culture, we don't know how to talk about death and dying. And so many of our decisions about our end of life care come in a moment of distress, when maybe we're in a medical office and someone is giving us a diagnosis, and all of a sudden we're stressed and we're scared, or we're scared for our loved one. And so in all of this, I think what I was really tuning into what Kelley was talking about, so much of what they do, they're a natural part of this journey called death, And part of what they're doing is helping families understand what that is and what it looks like, and they're help relieving them of that incredibly hard work of 24-hour care at end of life. So I guess if I could just say one thing, I am so glad there's an organization like Hospice Foundation of the Ozarks that was working toward this vision, met Kelley, could see it, and then still had a passion to bring it to Springfield. And that is where Camelia, who I know is on this call, came in. It's like we were willing to provide the money and willing to help problem solve, but you still need someone with that passion who gets care at end of life. And I tell you what, when our world intersected with Camelia's and Jacob's Ladder, that's how I'm going to hand this to Alecia. Springfield could not be more fortunate. We've got that start that Kelley emphasized. It is happening right now, folks. And I'm going to let Alecia and Camelia tell you about it.
Well, thank you so much, Regina, for that wonderful introduction. And Kelley, it was just so inspiring to hear you. I've heard so much about you and the mothership, as Regina said, with Clarehouse. And we, in every tour we give, I want you to know Clarehouse is part of our tour. And it's part of why we are who we are today, because of the wonderful example that you have led and given to us. So I can't wait to meet you here in a few weeks and meet you in person. And that's just going to be a great opportunity. But wanted to share with you just on behalf of Camelia, she is the most amazing human I have ever met in my entire life. I remember meeting with her the first time, and I've always considered myself a spiritual person, but she filled a hole that I didn't even know existed with her gift of just being who she is and the reason that she does this. And when anybody meets her, you will feel that same spirit, because she is just that incredible person. We're kind of yin and yang, I guess you could say. She is that caregiver. That's her side. That is what she does immensely with our caregiver, Lydia, that lives at the home, and our other caregivers that we have as well. And of course, our board of directors. I can't say enough wonderful things about each one of them. And we're all kind of in our infancy here, just opening September 1st. We're just on November the 5th, so we're not even 90 days in, and we're creating this wonderful board and this great opportunity for Springfield. So thank you on behalf of Camelia, the board, and myself. Thank you to the library for allowing us to come on and visit with you today. I am going to share my screen and just kind of show you can you see it, or am I not sharing it yet? Share, here we go. There we go. Can you see that?
Yes, we can see it.
Sorry, I am not the most technical person here, so. All right, so this is Jacob's Ladder. Just want to, for those of you that are on the call that can see this, we are Jacob's Ladder End of Life Legacy Home, and very proud to be in Springfield and serving all parts of Southwest Missouri. We get a lot of people that ask us, well, are you just serving Springfield? And absolutely not. We've had some of our guests be as far away as 2 hours that have come to us. And so that's been pretty amazing that we've been able to reach that far in the community, but that also tells us what a need there is if they're coming from 2 hours away. We're really proud of the fact that Jacob's Ladder is, of course, funded in part by Hospice Foundation of the Ozarks. Our friendship with Kim, it's invaluable. She's just an amazing person, as well as the board of directors, Regina, and all of you. We're very pleased and proud to work alongside of you in this. Our nonprofit is here to provide a loving and compassionate end-of-life experience for those that need that caregiving and person-centered care during that end-of-life journey. In our tours, we talk about it's not cookie cutter. Everybody's end-of-life journey is very different. There's not two people that are the same. There's not two families that they're same. There's not two hospices experiences that are the same. So we really want to make this very person-centered. And I think that's a real big philosophy at Jacob's Ladder, that everyone is treated as as an individual, their family dynamics as an individual, and we really want to respect that inside of our home. Much like Clarehouse, of course, they have to be a part of a hospice organization prior to coming into the home and working with their primary care physician to provide all of their medical oversight, while we are providing the caregiving and the loving environment for them to be in. We have a 24/7 on-site caregiver that lives with us in our home. Her name's Lydia, and let me tell you, that lady, she's impeccable. Absolutely impeccable with how she cares for people. The families just connect with her so much, even though there may be a speech barrier with language. You can tell exactly how much she cares for people. Patients, of course, must be enrolled with that local hospice provider of their choice. We kind of joke at our house that you leave your name badge at the door. We don't care which organization you're with, because once you enter our home, everybody's family. And that's been wonderful for the Springfield community. There's 17 hospice companies. And Kelley, when you said 80, I took a gasp, because I'm from the hospice world and I can't even imagine that many hospice companies, but 17 in our little area. And we, it doesn't matter who's bringing people to our home with hospice. And we just want them to have the same values and philosophy as what we do. Our staff and our volunteers, we have formed a volunteer tree that's just up and going. We're going to offer hands-on nurturing care to relieve pain, stress, anxiety, and that isolation, especially during this COVID time. It has just been, as we've all been feeling it, some sort of isolation. And imagine, I have one family that we had that very well-known family in the Springfield community. They had not touched their mom since March. They saw her through a window, but they had not been able to physically lay their hands on her hand since March. And they heard about Jacob's Ladder, immediately pulled her out of the nursing home, and they were able to spend 6 amazing days with her at her side. And that was a gift to all of us, to see that compassion and that reunion with that family. And they are just some of our biggest cheerleaders and will continue to be. And our main objective, of course, is quality end-of-life care for the patient and to support that family during their loved one's journey. But we're also going a step further with that. We are partnering with Lost and Found Grief Center in Springfield to provide resources, because for the family, their grief may have started prior to their loved one's passing, but it certainly doesn't stop. It's just beginning after their loved one dies. And we want to be able to offer those resources too. So we're encouraging them to participate in some guidance and counseling with Lost and Found Grief Center, which is just a wonderful avenue for them. So these are some pictures of the house. These are just some of our rooms. They've changed a lot since we took these pictures. For those of you that are local, you can tell, but the front of the house is, we've done a lot of shrubbery and greenery work there. This is our living room area. Down below that's we're getting ready to decorate for the holidays, so we're certainly excited about that opportunity as well. And then these are some of our guest rooms that we have. Of course, our hospice companies provide the DME. We did have a wonderful donation from one of our board members of a bed. So we do have one of our rooms that's equipped and ready to go, which is really nice as a visual for the tours that come in. So we're able to provide them kind of what the rooms look like. And then we have our coffee and our meditation room. That's just a place for people to step away and just have that time that they can just take a breather from being at bedside. Like Clarehouse, we have a beautiful outdoor area. I encourage everyone to go on our website. It's jacobsladdercare.org and check out our outdoor area. If you are local, I invite you to come by and tour. We are doing tours. We are limiting them to 3 people at a time, and masks are required. And there's a great opportunity coming up with our open house and grand opening, which we have 2 dates selected to offer some social distancing abilities. On Tuesdays, November the 17th from 10 a.m. to 4 p.m. And then on Saturday, November 21st from 9 a.m. to 2 p.m. And that's a come and go. Masks are required. Temperatures will be taken at the door. But we encourage everyone to come out and just take a look at this beautiful place that Springfield is so, so blessed to have because of Hospice Foundation of the Ozarks, as well as our other donors that we have in the community, and of course our board of directors. We couldn't do any of that without any of you. So thank you, Library, Springfield-Greene County Library. Thank you, Sarah, for allowing us to come on and talk about what we're doing at Jacob's Ladder. It's exciting. Every day is a new day, and we can't wait to grow and expand and be that forefront in the community for those that need help in their end of life journey. Be happy to answer any questions if anyone has any.
All right.
Michelle, I'm sorry, how many bedrooms do you have?
We're only opening 2 right now. We have a capacity of 8, but we're only opening 2 till we're able to sustain more. And right now, with the need, we haven't found that 2 has become problematic. We've been able to support the community needs. We didn't have a guest for 2 weeks, and then on Friday, within an hour, we had 2 moving into the home and 1 on a wait list. So it just kind of happens all of, sporadically. But right now, the 2 beds is working just fine.
And how are you doing with COVID-19 precautions?
So right now, we everyone is required to mask with inside the home. Families are limited to 3 people in the room, and as long as care is being done with their family member, everyone has to wear a mask while that care is being done. Hospices that are coming in, everyone has temp checked and masks are being worn. But when the family's in with their loved one alone, they may shut the door and have that private time with masks not being worn. We are not accepting, of course, any COVID patients in our home due to the safety and what's best for our house. And we want to, those that are coming from the nursing home and hospital have to have a clear COVID test within the previous 3 days.
And what kind of response are you getting from your hospices and hospitals?
Amazing. It is unbelievable. Like in any community, you got 2 hospitals that, are very different, and we kind of say the joke, they don't play nice in the sandbox together. And hospices are the same way, where they're very competitive. But we honestly, I can say it's been amazing to see all of them come together. And like I said earlier, Kim and I joke all the time to leave your name tag at the door. It doesn't matter what organization you're with. And they have really come together. They've all agreed to be on the phone tree. If we need a need for someone to come sit at bedside, they don't care if it's not their patient or not. They want to be a part of that. So it's just pretty incredible. Springfield's a small town, but the healthcare industry is even smaller. You know a lot of people, and it's just been very, very well taken care of.
That's awesome.
Yeah.
How many patients has Jacob's Ladder had so far? Alecia, guests.
We have welcomed 11 families through our home. So we're super excited with that. And it's been an amazing experience. We had one gentleman that was a homeless gentleman, and his last evening with Camelia and the story that she has is breathtaking, because he didn't have anyone. And he was refusing pain medicine because we think he was scared to die alone. And she was able to speak with him and tell him that, and clean him up, and able to love on him. And he actually felt comfortable enough to accept that help of being comfortable and accepting that pain medication. And he knew when he closed his eyes that he didn't wake up the next morning, but his last comfort was knowing he was in a home with love. And that's what we're here for.
Most definitely. It's a wonderful mission that you all are serving there at Jacob's Ladder and at Clarehouse. Brought up a topic of the family that their loved one was in the nursing home and transferred to Jacob's Ladder. If someone was interested in possibly starting that process, would they bring that up with their hospice provider?
They can do one of two ways. They can bring it up with their hospice provider. They can contact us directly, and we can work with the hospice provider. There's not really a right or wrong way of doing that. In this day and age, when hospices are locked out of nursing homes because of the COVID, we're allowing them all disciplines to come in and help with that end of life journey. That's so important to not only the family but the patient. So if we get a referral or something from a family member, these hospices are going to jump on it to be a part of it, because they're going to be able to go back to providing their services, which are so greatly needed.
Yes,
And
they
we've got
are.
referrals from hospitals, from hospices, and from people just that have heard about us. So the direction and the vision is out there in the community, even having just been open under 90 days.
What an amazing thing for the Springfield and beyond community, as you said. Such a resource for such a wide area of potential. Everyone else, please chime in with your questions if you have any for any of our panelists this evening. We appreciate their time so much. Kelley, I have a question for you. What's the average stay for a guest at Clarehouse?
Right now it's about 6 days.
Okay.
So we have people that, so I'll tell you this story real quick. We had a guest here, a gentleman in his 80s who had lived with us for about 5-6 weeks. And he was hanging on. And he hadn't seen his wife in all that time, because right before he came to Clarehouse, she got diagnosed with COVID and she went into the hospital. And she survived COVID and she went back home, but she developed continuous complications from the COVID infection, and she was back and forth to the hospital. So they never got to see each other again after he came to us. And coincidentally, his daughter, her husband had died in our home about 6 years ago. So this family already knew us, and we were their go-to, helpers. So the wife continued to decline and eventually was deemed to be at the end of her life as well. And they called and said, can we get her into Clarehouse? Can we reunite our parents before they die? So we did. So we brought her over, and she came in on a Friday afternoon about 2 o'clock, and we had the 2 bedrooms were side by side, but we were going to put them together. We just had to get her settled first. So we brought her in, got her off the gurney, got a pretty red gown on her, got her cleaned up a little bit. And then we went and got his bed, because he was bedfast as well. And we rolled his bed into the room beside her, and she took her last breath. Oh. And he was holding her hand for the first time in 5 weeks, and she died moments after getting here. But we were able to give him that gift, and he stayed in that room with her, and they held hands for about 6 hours. Family came, different family members came to visit. Family was overwhelmed. That they were overwhelmed with grief, but they were so unbelievably grateful that it happened this way, and that these parents got to be together for those final moments. She died, and funeral home came and picked her up, and he wanted to stay in that room. Even though he'd been in another room for 6 weeks, he wanted to stay there. And he survived another week before he died, but he did die last week, and it was such a bittersweet gift to give them.
Wow.
I'm like, dang it, Kelley.
Everyone has tears.
Yeah.
That's
Kelley,
amazing.
that's awesome.
What a story.
Thank you.
That is a great story.
And there are
it might
so
be
many
minutes.
wonderful stories.
They might be here for minutes, they might be here for hours. We've had somebody here for 6 months.
We're so glad that organizations like yours and Jacob's Ladder exist, so that we can have these stories and have these special moments for these families and their loved ones. So, and Amy chimed in that this is what this home is all about, and definitely. We have a couple more minutes. If we have any other questions. We are,
Alecia,
Yes.
are you worried about the money?
Don't ask that question. October, I have to say this though. So I got the financials today, and I won't give the specific numbers. However, we were $300 short of covering our expenses for the month of October. I was absolutely thrilled with that,
That's
being in business
impressive.
and open since September 1st. And it was a hefty 5-digit number of what our expenses were, and we were $300 short of being at 100% covered. And that was it was just incredible. It was incredible. So, but you know, November 1st is here. I'm a salesperson by background. November 1st is here. So October 31st is gone. So we start all over again November 1st. And so then, you know, that pressure works up, and you know how it is. So
That's great.
It's, you know, you gave us very good advice. And we have rehearsed it and recited it more than once. If you have the care, that is so, so pivotal. And then you're home. But by golly, come on, guys. And you challenged us. You're like, you've already got this. Come on, jump in, get started. Don't just stick your foot in the water, jump in. And, you know, we did. And I think it's a testimony to a lot of things that this opened in the pandemic. And, you know, the quote that you had from Margaret Mead was my past for the Community Alliance. That was our quote. And it is so true. And our family is growing, the people that we're reaching. And, you know, we do have, Kelley, I mean, you are our mothership. You have showed us the way to do things. You continue to show us and an example. And, you know, we're going to learn and learn well. And we're going to change death and dying in Springfield, Missouri and beyond, because that's who we are and that's what we do. And, you know, we have great encouragement. We have a great board. I have an amazing board at Hospice Foundation of the Ozarks who supports this mission, and it's onward and upward. That's our plan.
On that note, I do agree, Kim, there's a lot of love in Springfield, and I know that it's just waiting to embrace everything that Jacob's Ladder has to offer. And full disclosure, I do have to admit I am on the board at Jacob's Ladder, and we are just thrilled to be able to bring this to Springfield. So thank you all so much. We really appreciate your time this evening, and thank you for the mission that you are serving in your communities, helping people to die in peace and comfort. This has been a wonderful, amazing evening for the Death and Dying series, and thank you again to the Hospice Foundation for providing the financial support for us to be able to offer the Death and Dying series to our community. If we were at the library watching in person, we'd all be applauding right now. So thank you for sharing this important information and giving us all insight into the world of hospice homes and introducing us to Jacob's Ladder. And thank you again to our viewers for attending our virtual event with us. We hope you'll join us for our next program. Again, that's Funerals and the Impact of COVID-19 at 6 p.m. on Tuesday, November the 10th. And you can find a link to the event and the series schedule and the titles at thelibrary.org/death or library.org/programs to see our full schedule of events this fall and winter upcoming. Thank you, everyone. Have a wonderful evening.
Thanks, Sarah.
Thank you to the library for tackling this topic.